Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Oncology Today. As today we follow up on two recent programs, one on thyroid cancer and the other on neuroendocrine tumors. We're going to make rounds today. We have a great faculty, Dr. Jonathan Strosberg from the Moffitt Cancer Center in Tampa, and Dr. Lori Wirth from the Harvard Medical School and Massachusetts General Hospital in Boston. This webinar today, we've never tried anything like this. We like to try new things, but these are both follow-ups to recent Oncology Today programs. These are audio and video programs that we distribute. A lot of people end up listening to these as podcasts. We did an extensive program on thyroid cancer with Dr. Eric Sherman from Memorial Sloan Kettering Cancer Center. And there's so much content in there, we decided to spend another half an hour with Lori Wirth and present some cases and try to take it to the next level. Similarly, we did, again, a very extensive program. There's a presentation that goes through sort of A to Z of neuroendocrine tumors. So much to talk about there with Dr. Pam Kunz from the Yale Cancer Center. And again, Jonathan was nice enough to join us today to continue our discussion. And what we're really going to do is present cases. Just to let you know, in terms of upcoming webinars, tomorrow we'll be working with Lori's colleague at MGH, Dr. Nupur Raji, in the final series of program in our Meet the Professor of Myeloma series. Next Tuesday, we'll be working with Dr. Javari on a new series we're starting on, let's say, everything outside of HER2 positive breast cancers, so ER positive, triple negative breast cancer. Then on Wednesday the 1st, we'll be working with Dr. Flowers and Sen in our Year in Review series, looking at recent papers, particularly from ASH, on lymphomas. And then we have another a program on the 2nd, will be very interesting, specifically focused on adverse effects of therapy with BTK inhibitors, both in CLL and mantle cell. We're going to be doing a really interesting program on the 8th with Dr. Partridge and Miller, focusing on young women with breast cancer, and particularly the role of ovarian suppression and ablation. We're going to be going to the GU Cancer Symposium, where we'll be doing a symposia there that'll also be online for those of you who aren't able to go to San Francisco, starting on the 15th with the renal cell, the next night on prostate cancer, and we'll finish out with a symposium on urothelial bladder cancer. But today we're here to talk about two interesting tumors that are not as common in general oncology practice as what you just saw, myeloma, breast cancer, et cetera, et cetera. This is certainly an area I could use a lot of updating on, and I'm really happy to be able to spend some additional time on these complex subjects. And we're going to actually show very short videos from the two programs that we're talking about here today, specifically with case presentations. Basically, what we're going to do for the next hour is make rounds. So first, we're going to go through a bunch of cases of thyroid cancer, both Dr. Sherman's and Dr. Wirth's, and then we'll go through NET tumors, again, several cases with Dr. Kunz and Dr. Strosberg. So we'll we'll get back to Jonathan in about a half an hour. We're going to start out talking about thyroid cancer. Again, we're just going to go through cases. We'll start out talking about TKIs in thyroid cancer, and then get into, of course, all the excitement with targeted treatment. And then for the neuroendocrine tumors, we'll start out with a case of a patient who got TKI therapy, and then we'll get into targeted therapy. We'll take a quick look at VHL because it's such an interesting syndrome. So Lori, we're going to start out talking about thyroid cancer. We have 5 cases to go through, but I just want to take a breath before we get started here. And, again, this is nowhere near as common as some of the other tumors we see in general oncology. And I know you see a lot of second opinions. People have been managed in the community. Any myths or misperceptions or sort of global issues in thyroid cancer that you see as you see these second opinions that we ought to be thinking about as we get into CME on this topic?
Well, so first of all, Neil, I have to say, Nupur Raj's office is right next to mine. I'm going to have to resist the temptation to Zoom bomb tomorrow night. um,
That'd be a great idea.
Anyway, so I don't know that there are any myths necessarily, but there's certainly it's a rare disease. So there's an unmet need for education. Not all thyroid cancers are the same by any means. Not even all differentiated thyroid cancers are the same. And now, so many thyroid cancers really are molecularly driven by mutations or fusions that are druggable. So any patient who has an advanced thyroid cancer needs to have molecular diagnostic testing to identify the best therapy. That's really kind of key.
So we're actually going to start out again with cases, and as we get into that, you'll be able to elaborate a little bit more about how you approach various situations within this. Incidentally, last night we did a webinar on gynecologic oncology, and your former colleague who then went to University of Arkansas, Mike Beer, noticed we were doing the webinar tomorrow, said to say hi to you. Always interesting to hear about the MGH people as they go out various places. But let's start out, of course, the big, as you mentioned, the really excitement, I think, in thyroid cancer is targeted therapy. But let's just begin with a case where there wasn't a target, and we can talk a little bit about treatment of those patients, particularly the issue of TKIs. This is a 69-year-old woman who's in your practice who actually got started on lenvatinib first, and we'll hear then on progression got cabozantinib. Can you talk a little bit about how she presented and what happened when you started the lenvatinib on her?
Yeah, well, so she had a long history of thyroid nodularity that was chalked up to multinodular goiter. Maybe there was really tumor there for a while after, in retrospect. She had actually been radiated for an enlarged thymus when she was an infant. We'll talk about that more in a sec. But so she was diagnosed with thyroid cancer by an FNA. She underwent a thyroidectomy. The pathology of the thyroidectomy specimen looked ugly. It was a poorly differentiated thyroid carcinoma with a lot of invasion, vascular invasion, extrathyroidal invasion. She had radioactive iodine postoperatively, as most more advanced cases do. There was only uptake in the neck, so probably just some residual normal thyroid tissue. Just a couple of years after she had her thyroidectomy, she presented with a rising thyroid globulin, and then imaging showed what you can see there on the CT scan, a nodule that really looks like it's kind of embedded in the sternocleidomastoid muscle on the right side. Again, that's like a bad looking thing. So she was diagnosed with recurrent disease. She had surgery. She had some small lung nodules at this particular recurrence. So we did molecular testing at this point, and we actually found this unusual fusion, which hadn't been previously described in oncology that we could find, but probably is a driver alteration, probably leads to expression or upregulation of IGF-2. And the reason why I mentioned the radiation in infancy is that in people that have had radiation and have thyroid cancer, they're much more likely to harbor these oncogenic kinase fusions. So again, she had more surgery, she progressed again. Finally, we needed to start treatment. She didn't have anything druggable, so we started lenvatinib, which is the first line multi-kinase inhibitor. We started at the full recommended FDA-approved dose. She developed the very typical treatment emergent side effects of hypertension. You can see hypertension on lenvatinib like that. So you have to be very aggressive in managing the hypertension. She developed treatment emergent diarrhea. We had to dose reduce. She actually had really bad proctitis. I needed to get GI colleagues involved to manage her proctitis and further dose reductions. Fortunately, though, she had a response, so it was sort of worth all of this pain and agony for her. But the response didn't last long. The median duration of response with lenvatinib normally is around 3 years, but her response didn't even last for a year before a new nodule emerged in her neck. So again, I think
Before
that
you,
was, yeah, go ahead.
I was just going to say, but before you keep going, just take a breath before we go to the next part here. Maybe you can comment a little bit more about using lenvatinib in this situation. It's interesting thinking about Mike Beer. Last night we were talking about lenvatinib Pembro. He was actually talking about, I think, work that he did at MGH where weight loss was seen with lenvatinib, which I thought was kind of interesting. But of course, the big issue is exactly what happened. And again, we talked about it last night. I mean, 24 milligrams in again, I mean, I know it's with Pembro, but you start at 20, and most of the GYN people don't even start that high. They preemptively go down. So how often are you able to actually give 24 milligrams? How do you prepare patients for this? Do you have them take their blood pressure? We were talking about that last night. And how would you compare this course to what you typically see?
Yeah, so all really important points with lenvatinib. There was the FDA mandated AZI, the pharmaceutical company that makes lenvatinib, to do a dose-finding randomized trial. So there was a comparison between 24 milligrams and 18 milligrams in thyroid cancer. It was a non-inferiority study, and 18 milligrams was not non-inferior. So the response rates were lower with 18 milligrams, and the toxicity really wasn't any better. So the 24 milligram dose came out as the best dose to use for most patients. I use the 24 milligram dose, but part of the baked into the process is dose holds and dose reductions and a lot of supportive care. And so most patients do have to have dose reductions, but I do have a few people who've been able to be maintained on 24 milligrams for a long time. The hypertension really is an important thing to be aware of because you can get significant hypertension. The onset can be very rapid. So we make sure that people are normotensive before starting it. We make sure that patients have good education, have a blood pressure monitor at home, are monitoring their blood pressure on a daily basis and keeping a diary of it. And we tell them to call us the first time they have hypertension. And I've educated my nursing staff to don't tell them, oh, great, well, you've got an appointment next week. We can talk about it then. As soon as we see treatment emergent hypertension, we start treating it.
So this patient, interestingly, actually had an oligomet radiated with IMRT to the neck, but then ended up going on cabozantinib. And I believe last March, and the patient now, it's almost a year, still on cabozantinib. How did the patient do on cabozantinib, both from the point of view of the tumor as well as toxicity?
Yeah, so cabozantinib was studied compared to best supportive care in the second line or beyond in patients that had progressed on a first-line VEGFR multikinase inhibitor. And based on that study, cabozantinib was FDA approved for the second-line setting with an objective response rate of 12%, I believe. But there was a significant improvement in median progression-free survival. So it is a bona fide second-line multikinase inhibitor for these patients. So that was the go-to drug for her. She actually had a beautiful response. I started her at 40 milligrams rather than the recommended phase 2 dose of 60 milligrams because of her prior GI toxicity, which she couldn't have gone back to that. She had a little bit of diarrhea, mild hand-foot syndrome, but has been able to stay at the 40 milligram dose. And she's had a beautiful response. She remains in response, and she's been in response longer than her first line lenvatinib, which is kind of unusual, and I was pleasantly surprised.
Interesting. Okay, let's talk about targeted therapy. That's what everybody wants to hear about. That's what all the excitement is. And here we go with a case from Dr. Sherman, a 61-year-old woman with metastatic papillary cancer who was found to have an NTRK fusion.
Really sweet 61-year-old woman. She got radioactive iodine, and then she did really well for many, many years. Around 2017, we know that her tumor was growing, but really, really slowly. And at that point, we decided to really do like full sequencing of her tumor. And we actually went ahead and did a biopsy for that. We actually ended up having to do RNA-based testing, not just DNA-based. And we actually found out that she had an NTRK1 fusion gene. She was only the second person I had that I actually found an NTRK fusion gene. Even though we found that, we didn't think she needed to start treatment, so we kept just watching her. But at the end of 2018, she actually started to notice that these nodules started to develop on her right arm. And she actually had some subcutaneous nodules develop on her head as well. We did re-imaging of her, a PET CT scan, and now she also had developed new lung nodules. So we biopsied one of the lesions on her right elbow, and it actually now showed that she had anaplastic transformation. Though the NTRK fusion gene was there, which is what we would have expected, we actually decided to put her on a clinical study with a drug, repotrectinib, which was like a new second generation NTRK inhibitor. And she actually remained on it between February of 2019 to March of 2022. In 2019, median progression-free survival is only about 3 months with metastatic anaplastic. And you can see she was on this for 3 years and still is alive and kicking.
So, any thoughts about the case? Maybe you can comment a little bit about the RNA testing. You know, we talk about that in lung cancer. They think about it for non-smokers, but that's not an issue here. So, do you get it on everybody who doesn't have a mutation on NGS? And then also, I don't know why, it sort of seems surprising to me. I don't know that you would see such great responses to targeted therapy with anaplastic, but I guess that's the case. So, any comments about those 2 points and about the case in general?
Yeah, so the RNA-based tests are the best tests to detect a fusion. So in thyroid cancer, about 15% of the adults with a differentiated or anaplastic thyroid cancer will have fusions. And then a higher percentage of adolescent and young adult patients will have fusions. So we do our in-house fusion assay in all of our patients that we're doing molecular diagnostics on. We order it in parallel with the mutational based testing for the sake of time rather than doing them serially. But doing them serially would be a legitimate thing to do as well. One of my take home messages with these looking for fusions is that these kinase fusions all have multiple 5' fusion partners, and it can be very difficult to detect, to have an assay that can detect every single known 5' fusion partner, plus ones that haven't been previously described. And so I happen to like the Archer assay for fusion detection, because that's agnostic to the 5' fusion partner. So you won't miss, in theory, a single fusion if you use the Archer assay.
Any comments on the response to targeted therapy with anaplastic or patients like this that evolve into anaplastic?
Yeah, well, so first of all, that de-differentiation to anaplastic thyroid cancer actually does happen. And so I'm glad that Eric showed this case. And going and doing a biopsy of something that's not behaving right compared to everything else, and when you're taking care of somebody with a differentiated thyroid cancer, really should be considered to rule out anaplastic thyroid cancer. And this is a perfect example. So it does happen. You know, I'm surprised in a way that the patient had such a beautiful response for so long with repotrectinib, because larotrectinib has been studied in patients with NTRK fusion thyroid cancer, including anaplastic thyroid cancer. And in the anaplastic subset of patients, the response rates were much lower than in the non-anaplastics, and the duration of response was really much shorter as well. So I don't know, maybe repotrectinib really is a better drug in that particular case. You know, Neil, one other thing that I would say is that we have seen beautiful responses to gene-specific therapy in other anaplastic thyroid cancer cases. We see that with BRAF mutant disease and BRAF-directed therapy, and also in the RET fusion-positive anaplastic thyroid cancer experience, we now have treated several patients and seen some really beautiful, durable responses with anaplastic.
So you also had a case of a patient with an NTRK fusion. This patient got larotrectinib that you just referred to. Before you comment on what happened to this patient when the patient got larotrectinib, can you just review what the available agents are, how, from your point of view, they compare, and whether you have any preference?
Mm-hmm. Yeah, so larotrectinib and entrectinib were the first two drugs that were FDA approved that target NTRK. Larotrectinib is a TRK-specific drug that inhibits TRK 1, 2, and 3, whereas entrectinib also has activity against ROS1 and some ALK activity as well. The thyroid cancer experience with larotrectinib was a little bit, there were more patients on the larotrectinib series with thyroid cancer than in the entrectinib series. In the NTRK fusion positive thyroid cancer patients with differentiated thyroid cancer, the objective response rates were very high, close to 90% with very durable responses. Whereas with entrectinib, it's just a smaller series of patients that have been treated so far. And the response rates aren't quite as high in differentiated thyroid cancer. And also the durability isn't quite as long. So based on those two apples to oranges comparison, when I have an NTRK fusion patient, I usually use larotrectinib as my first line therapy.
Again, I know oncologists are sitting out there, kind of comparing what we hear in lung about targeted therapy. Because in lung, one of the issues is how CNS penetrant it is. Is this much of an issue in thyroid cancer? Obviously, in lung, you see a lot of brain mets, and so that's an important consideration. What about in thyroid?
Well, it is a consideration. We see in patients with advanced thyroid cancer, not anaplastic, we see a CNS metastatic rate of about 10%. So not quite as frequent as with lung cancer, but still frequent enough that you want to think about doing a brain MRI. Larotrectinib has good CNS activity as well as entrectinib does.
So anything you want to say about these images? It sounds like a real success story here.
So, this is it's a great success story. This guy is a neurologist who does research in Alzheimer's disease in Florida.
Wow.
So we want to keep him going.
Yeah.
We started him on larotrectinib on the clinical trial in late 2016. After 4 cycles of therapy, he was in complete response, and he had a beautiful drop in thyroglobulin tumor marker. And he remains on study. Remains in response today. He has a complete response to treatment. His thyroglobulin still is a little bit measurable, so I think there are some thyroid cancer cells kicking around there. But he still works full time. He has no side effects from larotrectinib, and we're just keeping him going.
So we're going to touch also on RET. We have a case from Eric and another case from you. Could you just provide an overview, though? I was really fascinated by what Dr. Sherman was talking about in terms of medullary, both the genetic form as well as the sporadic. Globally, what is the incidence of RET alterations? Also, you have RET mutations and fusions. In lung, I hear more about fusions. So what's sort of the broad overview of RET and thyroid?
So it's complex, but it's not really all that complex. The most common thyroid cancers are differentiated thyroid cancers. We see RET fusions driving about 10 to 12% of those differentiated thyroid cancers. And it's the same sort of RET fusions that we see in non-small cell lung cancer with the same 5' fusion partners like CCDC6, KIF5B, same mechanism of action. And then about less than 5% of all thyroid cancers are medullary thyroid cancer. Now, there are familial medullary thyroid cancers in MEN2A or MEN2B. Those make up about 25% of all people with medullary thyroid cancer. You have to rule out a germline RET mutation in every single new case of medullary thyroid cancer, even if there's not a family history because of all of the vagaries involved. But all patients with a familial medullary thyroid cancer will harbor a germline RET mutation. But of the 75% of sporadic medullary thyroid cancers, 60% of those patients will have somatic RET mutations in their cancers. So we do tumor genotyping in everyone with medullary thyroid cancer and have a very high hit rate for finding actionable RET mutations in the tumors.
All right, let's go through a couple of cases, and we've got good questions coming into the chat room. We'll see if we can get a couple of those as well. So I love hearing stories like this. 41-year-old man, here's the case.
This was a really fascinating case. So this is a fairly young person, 41-year-old. He presented actually in an outside hospital with a severe diarrhea, 20 to 30 episodes per day, losing a ton of weight, abdominal pain, epistaxis, CAT scans were done. He had actually mets throughout his thyroid and neck, lung mets, and also liver mets. And I show an example of his liver there. His liver is like just full of cancer. And I'll tell you, he was in pretty bad shape altogether. He already had a biopsy surgery done on the outside that showed medullary thyroid cancer. As soon as we got to think about medullary, the first thing we did was get his tumor tested for a RET mutation. And luckily, his tumor did have a RET mutation, and we started him on selpercatnib. He was in such bad shape that about 2 days after starting treatment, he got admitted to the hospital. We made sure he stayed on the drug, that nothing was going to stop him from being on it. And while in the hospital, he actually developed severe ascites. His legs became very edematous. He was pretty still sick for really the first 6 weeks. The thing was is that if you see his tumor markers, they went down really quickly. So he started treatment on February 14th. By just in a week, his calcitonin had gone down to less than 9,000, and his calcitonin CA continued to drop. And then you can see that basically a few months later, we get this CAT scan, and his liver looks great. The disease has disappeared completely, and he actually showed up to see me in clinic about a month after he was discharged from the hospital. And he's walking around. He's no longer in a wheelchair. His edema is almost completely disappeared. He just feels great, and he's back to normal life. And it's just amazing how sick this patient was when he first started, how much of a big burden he has, and how this really disappeared within 1 to 2 months to the part where he's fully functional, back to work, doing everything again.
So one more thing I'm just going to add before I ask for your comment and whether you've seen cases like that, Lori. One other little tidbit on this case. When he said he got started on treatment on February 14th, Valentine's Day, the year was 2020 in New York City. And I know you in Boston at that time also, New York and Boston, that was where COVID. So all of this was going on while COVID was coming into New York, incidentally. Any thoughts about the case? And then, of course, you have your case of a 43-year-old patient, metastatic medullary, also who got selpercatnib. First, any comments on Eric's case?
Yeah, I liked, so Eric and I are close colleagues and probably kind of close in age. And I like how he said a really young man who's 41, definitely showing our age. So what I would say about that case is that Eric didn't just cherry pick the best case off the shelf. I have cases like that too, of patients with a huge burden of disease, also very heavily pretreated, who were coming in very close to what we thought was the end of life. And then, we were able to get them on either the selpercatnib or pralsetinib studies as they were first opening up. And I have a very similar case where very impressive CT scans. The guy still is in complete response to date after being one of the first patients enrolled on the selpercatnib clinical trial. So we see responses like that.
And of course, we work with your colleague, Dr. Gaynor, in lung cancer, talking about RET alterations a lot. We learned a lot from him and his colleagues in your lung department. What about your patient? Anything you want to say about this case? This patient, I guess, started out with TKIs, and then you found the RET mutation. What happened with this patient once he got started on the selpercatnib?
Yeah, so he was diagnosed with medullary thyroid cancer. We ruled out a germline RET mutation, so we know he didn't have MEN2A or 2B. He was treated on cabozantinib. He had an initial response, but then progressed. We identified a somatic RET mutation in him, and when he progressed on cabozantinib, we enrolled him on the Libretto 001 trial. And you can see on these CT scans, he also had a huge burden of disease, but it was mostly in his neck and in his mediastinum. He had a beautiful response to selpercatnib as well. His calcitonin and CEA dropped beautifully. He felt a lot better. Calcitonin causes diarrhea, so all of these patients have bad diarrhea syndromes, and their lives, the quality of life is so much better when that diarrhea goes away. That happened with him. The patients all get fat after starting selpercatnib or pralsetinib because they don't have so much diarrhea any longer. He he unfortunately progressed, but he had oligoprogressive disease. It was just that one left paratracheal mass that you can see on a CT scan where he progressed after 4 years on selpercatnib. So we biopsied that lesion and we found a KRAS mutation that's an acquired resistance mutation that explains, I think, the reason that he progressed in that one spot. But it was only in that one spot and he remained in response. You can see on those tumor measurements on the right there that everything else remained in response except that one lesion. So we got permission from the study sponsor to hold selpercatnib. We treated him with a pretty high dose of radiation to the mediastinum. And then we resumed treatment on study with selpercatnib. And he remains otherwise in response. It's still by RECIST criteria, progressive disease because of that oligoprogressive disease. But every place else, he still is in response. So the reason why I wanted to show this case is that occasionally on these gene-specific therapies, we see oligoprogressive disease. And if you can do surgery or if you can do radiation or some other ablative technique and then keep the other treatment going for as long as possible, I think that we're learning that that's a really good strategy in this particular situation.
So we're going to switch over to Jonathan in a second, but just a couple more questions. First of all, in terms of the two approved options, any preference, any way to separate them? Is it, a lot of times in oncology, we have 2 targeted or 3 targeted agents. No way you can separate them based on the data. Is that the way this is?
I think so. We had both studies open at the same time from the beginning, and initially if we had a phase 1 slot on the pralsetinib study, a patient would go on that study. If we had a phase 1 slot on selpercatnib, the patient would go on that study. So I've used both drugs a lot, and the efficacy of both agents is really excellent. The FDA approvals are very similar, so I don't think that there is any real meaningful difference that we know of that would suggest one is better than the other.
So one final question before we get into NET, and I love to bring this issue up in our lung programs to get the investigators' blood pressure up, because everybody in lung wants to know, can they use targeted therapy in the adjuvant setting where the only thing that's approved is osimertinib for EGFR. If I put up a case of RET, everybody goes, oh, we want to give that patient adjuvant. So Hassan in the chat room has a patient with medullary cancer RET mutation, but status post-surgery, 4 positive nodes out of 10. And then Thoy has a patient with medullary status post-resection, and a little bit of increased uptake at the surgical bed post-op and rising CEA and calcitonin, but nothing else. Would that be enough to start a RET inhibitor? You need to wait for gross metastatic disease. So adjuvant and let's say sub-macro metastatic.
Yeah. So, if in medullary thyroid cancer, we have these beautiful, very sensitive tumor markers that we can follow. I love the question. We are working very hard to develop a multi-center adjuvant trial in patients with medullary thyroid cancer who have rising calcitonin and CEA. I'm hoping that within this year we will be launching that trial at 10 centers. Guys, reach out to me at Mass General if you're interested in talking a little bit more about seeing if there's a way to hang on to those patients and refer them for clinical trials in the future.
And
I think that we can change the natural history of the disease by treating these patients much earlier in the course of disease. I wonder if we can even, get to a point where we're curing patients with these very potent therapies.
So, in lung, we also argue about this, and, do you put them on a trial? Do you try to get it outside a trial? But, hopefully we can get these trials done to get definitive answers. Anyhow, Laurie, thank you so much for joining us on Rounds here today. We're going to move on and talk with Jonathan about NET. So, Jonathan, I know you've been kind of watching what we just did. I'm going to start out, and here's where we're heading here today. Again, we're just going to go through a bunch of cases, and both from Pam, who presented it in our program, as well as you have some cases. But again, just kind of taking a step back from a macro perspective in terms of this whole area. I'm curious kind of what your experience. Our primary target audience has always been the general medical oncologist. These are rare tumors, but yet they're highly prevalent tumors. Any sort of, I'm not going to say mistakes, but myths or misperceptions or sort of broad strokes about NET that you want to bring up from the point of view of docs who don't see it every day like you do?
Sure. I think the most important thing to remember about NETs is that it's not one cancer. It's a whole family of cancers and a very diverse one. They range from extremely unaggressive to extremely aggressive. And each primary site has its own unique characteristics. For example, pancreatic NETs are on average fairly chemosensitive. Small bowel NETs are not. Ileocecal NETs, almost always malignant, even if they're slow growing. Appendiceal NETs that are right next door, almost never metastatic. Very diverse group of tumors, very, very hard to generalize.
Yeah, when I talk with investigators, I kind of sometimes I think about sarcomas because they kind of say the same thing. There's no, you got to really look at each individual person. Well, that's why we're making rounds here today, just to get a little bit of a flair of how you see these cases. And we're going to start out with a case from Pam. I call this patient young, incidentally, 50 years old, even not to mention 41. But anyhow, well-differentiated small bowel NET with low volume liver mets. Here's Dr. Kunz.
So this is a 50-year-old woman. She has a newly diagnosed metastatic, non-functional, well-differentiated neuroendocrine tumor. It's a grade 1. Ki-67 is 1%, and it's of a small bowel primary. She has pretty low volume liver metastatic disease, and it was actually found incidentally at the time of a hysterectomy. The small bowel primary tumor was surgically removed. So the question is, what is the next best step? Observation, somatostatin analog, lutetium dotatate, capecitabine temozolomide, or liver-directed therapy. The two figures I've shown you, one is a cross-sectional imaging using an MRI abdomen through the liver. You can see the hypodense liver lesions. And then also we see the gallium-68 dotatate PET CT with a number of lesions in the liver.
So this patient actually ended up getting observed, but I'm curious how you think through cases like this, Jonathan, and what situations you would observe and what situations would you treat and what you would treat with.
Sure. So incidental diagnosis of metastatic disease is not that uncommon these days. And this patient is asymptomatic, so doesn't necessarily require treatment. The first thing we try to consider is whether the patient is surgically debulkable, meaning can a surgeon go in and remove almost all the disease? In the past, 90% of disease was a threshold. People have said maybe 70%. But the bottom line is there's a huge diversity in terms of what surgeons are willing to do. And some surgeons might look at this and say, I can operate and remove almost everything. So that's the first thing to consider. Assuming that's not the case, then the next thing is whether to initiate treatment or not. And the typical first-line treatment would be with a somatostatin analog, which is used both for syndrome control as well as for tumor control. Now, this patient, of course, doesn't have a hormonal syndrome, so it would be to stabilize disease. But, when we look at the phase 3 trials, both PROMID and clarinet with octreotide and lenvatinib, the drugs clearly can stabilize disease, delay progression. Neither trial showed an overall survival benefit. They really weren't powered for that, and pretty much everyone crossed over. But what this tells us is that, the patients who were randomized to placebo and crossed over probably did as well as the patients who started off on active treatment. And so you can extrapolate from that it's probably okay to observe patients whose disease burden is quite low and then start them on treatment once they progress. And again, the first line treatment typically would be a somatostatin analog.
And what is your typical choice of somatostatin analog?
So, octreotide, the phase 3 study was the PROMID study, which looked exclusively at midgut, small bowel NETs. Clarinet, which was lanreotide versus placebo, looked at a more diverse group of enteropancreatic neuroendocrine tumors. But, the hazard ratios for both drugs were quite similar in terms of delaying PFS or time to progression. And I don't think there's a big difference between them. As far as ease of administration, it's a little bit easier with lenvatinib, which comes in a pre-filled syringe. And so generally the preference in our institution is lenvatinib, but there's not a big difference, I think, in the drugs in terms of efficacy.
So Christine in the chat room wants to know, what about hepatic liver-directed therapy like Y90 in a patient like this?
Right. So liver-directed therapy comes in many forms, of course. Surgery is a liver-directed therapy, and that's a question we ask at the beginning. Is this an operable patient? Embolization is more of a treatment we think about for patients with progressive disease. So if this patient progressed on a somatostatin analog and had liver-dominant disease, as this patient clearly does, liver embolization would usually be our choice. Now, I would typically not recommend so there are different types of embolization, of course. There's bland embolization, there's chemoembolization, there's radioembolization, and I don't think they're interchangeable. Bland embolization has more short-term side effects than radioembolization, but almost certainly fewer long-term risks, and specifically risk of liver dysfunction. So for a while, we were doing radioembolizations on most of these patients, and what we found is that a certain percentage developed long-term pseudocirrhotic changes. The liver became fibrotic. Some patients developed jaundice and ascites. And so in a patient like this, where it's scattered by lobar disease, radioembolization would not be our first choice. On the other hand, we feel that if you have a more aggressive tumor that's more focal, you can do a radiation segmentectomy, for example. That may be more effective in some patients than bland embolization. In patients who are refractory to bland embolization with relatively aggressive disease, we might take the risk and do radioembolization even if we're embolizing both lobes. But the bottom line is, for relatively unaggressive tumor with bilobar disease, Y90 radioembolization is typically not our treatment choice when it comes to embolization.
All right, another case from Pam, 60-year-old man, well-differentiated small bowel net, has stable disease and octreotide, but now having increasing diarrhea. Here's the case.
This is a 60-year-old man who has a 5-year history of a metastatic, well-differentiated WHO grade 1, Ki-67 of 2%, small bowel net with low volume liver metastases. The patient has been on octreotide since diagnosis, with control of diarrhea and flushing and stable disease on scans, but recently the diarrhea has increased from 2 bowel movements per day to 6 bowel movements per day, but the disease remains stable. So on the right, you can see the MRI of the abdomen. It shows some low volume liver disease. Those are hypervascular lesions in the liver. So the questions are, what is the next best step? Would you add telotristat? Would you start lutetium dotatate, capecitabine temozolomide, or consider liver-directed therapy, either bland or chemoembolization?
So any thoughts about what you heard so far, Jonathan?
Sure. So metastatic small bowel neuroendocrine tumor with carcinoid syndrome, having increasing diarrhea, but stable disease. So first you want to try to figure out whether the diarrhea is related to carcinoid syndrome. Typically, you would look at the urine 5-HIAA. You could, there's also other assays like plasma 5-HIAA or serum serotonin. Serum serotonin, there's a higher false positive rate, so we prefer the 5-HIAA. Because it's important to remember there are other causes of diarrhea in this disease. For example, somatostatin analogs can cause malabsorption, pancreatic exocrine insufficiency. But assuming that you think it's related to carcinoid syndrome, then and it's stable disease, you could consider telotristat. Telotristat is a tryptophan hydroxylase inhibitor. It basically blocks the cellular generation of serotonin, conversion of tryptophan to serotonin. So it lowers serotonin levels and has been shown to palliate diarrhea to some extent in a randomized clinical trial. So it's used in addition to a somatostatin analog for control of diarrhea in patients with suboptimal control of diarrhea on somatostatin analog. And that's been defined generally as at least 4 bowel movements a day or more. That's considered suboptimally controlled diarrhea. So telotristat would be a very reasonable choice. Alternatively, you could perform liver-directed therapy. Liver-directed therapy tends to be quite efficacious for controlling hormonal syndromes in patients with liver-dominant disease. The other effective therapy for metastatic small bowel neuroendocrine tumors is lutetium dotatate, peptide receptor radiotherapy with lutetium dotatate, which is a radio-labeled somatostatin analog. But that's generally used for patients with radiographically progressive disease. It's rarely used just for control of hormonal syndromes.
So here's the follow-up for the patient, and as you suggested, the patient was given telotristat.
For this patient, we actually started telotristat. The reason being the scans were stable, so I didn't need a tumor control agent. I needed something to better control the patient's carcinoid syndrome diarrhea. Telotristat as an oral agent is pretty easy for patients to take. It is TID, but it's oral, so not another injection. He improved by 2 bowel movements per day. But I'll add one other thing to this, is that on the clinical trial that led to telotristat's approval, there was an observation that patients on telotristat had stable disease. So there's really this question, as it's not approved as an anti-tumor agent, but I think there's a lot of interest in studying it in that space. So we don't know yet, but I think this patient went on to have stable disease for a while, and it's hard to know if it's the biology, if it's the octreotide, or if the telotristat's helping at all.
So, Jonathan, you also have a patient who got telotristat, a 60-year-old man. Any comments about Pam's case, and also her thought/question about whether it actually affects underlying disease?
Yeah, my case is very similar. I don't know if we have to go over it, but basically another case of a stable patient with radiographic stable disease who was treated with telotristat for refractory carcinoid syndrome. As for the disease stabilization, there's certainly no high-level evidence. I would argue there's not even really low-level evidence of that. I think at this point it's speculative. If we want to study that, we need a randomized clinical trial.
You make the point in your case right up in terms of the echocardiogram and the fact that your patient had mild, moderate tricuspid regurgitation. What do you see in terms of valvular issues nowadays? Is the aggressive therapy of these patients kind of preventing that from happening, or do you see people who have major valvular problems?
No, we certainly see major valvular problems in some patients. It's not that common, but these are patients with carcinoid syndrome, and usually pretty severe carcinoid syndrome. So either because they were diagnosed relatively late in their course of disease, or because they've been living it for a long time and have become refractory. It correlates directly with serotonin or 5-HIA levels over a long period of time. So the higher the levels are, the longer the levels are elevated, the higher the risk to the heart valves. And we're talking specifically about the right heart valves, tricuspid and pulmonary valves, which can become quite fibrotic, and eventually patients can develop right heart failure. So it's important to screen at-risk patients. And again, these are patients with carcinoid syndrome. These are not all NET patients. And you can argue whether there should be a threshold cutoff for urine 5-HIA, say, 3, 4, 5 times above upper limits of normal. It rarely happens if the levels are just slightly elevated. And, the standard method for surveillance other than physical exam, looking for a murmur and JVD, would be with an echocardiogram. So we often do annual echocardiograms in patients with carcinoid syndrome.
So Dr. McKenna in the chat room wants to know, can you use telotristat without octreotide? And I'll add on to that, any tolerability issues with telotristat?
So telotristat tends to be fairly well tolerated. One of the side effects is constipation, which is not unwelcome. For some patients at least, I don't see that too often. The trials have been pretty small, so it's hard to know from the clinical trials what the entire range of side effects might be. Some patients a small minority of patients just don't feel great on the drug, but most patients tolerate it well. There are theoretical concerns about impact on mood because it lowers serotonin levels, but it doesn't really cross the blood-brain barrier. So far we have no significant evidence that it can cause depression. Some patients have mild LFT abnormalities, but overall relatively well tolerated. As to whether you need to use a concurrent somatostatin analog, the answer is the trials have pretty much all included patients who have been on somatostatin analog, but it's not 100% necessary. If the patient for some reason doesn't want to be on a somatostatin analog, doesn't tolerate it, you could use telotristat without a somatostatin analog.
So ever since I heard about belzutifan and our renal cell cancer programs, I've been fascinated by it. And of course, it's approved in patients with von Hippel-Lindau syndrome. And if you look there, it's also, and you see it with pancreatic net. Actually, Laurie did not have, and she's never used belzutifan. I'm sure most docs in practice haven't, but amazingly, you have. You have this 49-year-old lady, so I'm very curious about this in terms of what happened. I realize it's pretty rare, but it's just so interesting. So what happened with this woman?
Yeah. So this is really a 1 in a million case, and I don't think there have been, as far as I know, there haven't been any other patients with metastatic pancreatic net who have received belzutifan. So just to take a step back, von Hippel-Lindau disease is, it has many manifestations. It can cause, of course, renal cell cancer. It can cause hemangioblastomas primarily in the spine. It can cause pancreatic cysts, and it can cause pancreatic nets. And often those are multifocal, small, localized ones. And in this clinical study where they tested belzutifan, which is a HIF-2 alpha inhibitor, in patients with renal cell cancer, kind of almost incidentally, they found that patients who happened to also have pancreatic neuroendocrine tumors, there were 22 of them, the neuroendocrine tumors shrank. So these were all localized pancreatic neuroendocrine tumors, and 20 out of 22 had significant shrinkage, which led them to realize that this drug not only works for renal cell cancer, but also works for pancreatic nets. So this was a 48-year-old woman. Her history goes back 2 decades when she had lumbar and spinal hemangioblastomas. In 2007, she was found to have a left renal lesion. She had a partial nephrectomy. At the same time, she tested positive for VHL, and she did have a positive family history as well. In 2017, she presented with abdominal pain, and she had a pancreatic uncinate tumor as well as several liver lesions. Biopsy of the pancreatic mass showed well-differentiated net. She had a gallium-68 dotatate PET scan, which looks for somatostatin receptor expression, and showed uptake in the mass. It was considered locally advanced, unresectable, and so we started her on neoadjuvant treatment. Now, we don't usually use sunitinib as a neoadjuvant therapy, but we felt that given the vascularity of VHL-associated tumors and the fact that it works in renal cell cancer as well, we decided to go with that in addition to lanreotide. And she did have a minor response, but not enough to operate. So we then switched to capecitabine temozolomide chemotherapy, and she had another minor response. And then eventually she underwent Whipple surgery, where she was found to have a 3-centimeter net, multiple lymph nodes, and Ki67 of 18%. She developed tiny liver mets in 2019, or actually a single one. It was ablated, and she began resumed somatostatin analog therapy, this time with octreotide. She progressed further. We resumed sunitinib. She progressed further a year later, and we tried everolimus. And then she had further progression, and that was right when belzutifan was FDA approved. And so we decided to go with that. And she really had a phenomenal response, a near complete response that was even noted after 3 weeks. The urology team had ordered an MRI that happened to be 3 weeks after our CAT scan, and even in 3 weeks, there was a significant response. And subsequent scans have shown further response to the point that at this point, her tumors are almost undetectable, and her renal tumors have shrunk as well, and tolerating it very well.
So I don't know if you know who Ross Camage is. He's a pulmonary known for his work in pulmonary investigator, University of Colorado. He has been talking in our webinars recently about the idea of putting patients in a time capsule, by treating them with agents that maybe aren't the greatest, just keeping them alive long enough to be able to get a breakthrough in research. And it seems like it kind of applies to her. You struggled along with all these other therapies and then finally found the therapy that worked. Any other comments about that? Obviously, it's so rare. Any tolerability issues with the belzutifan?
Well, with my N of 1 so far, nothing. I mean, initially she had a small number of side effects, anemia, mild fatigue. These have largely resolved, so she's doing very well. Yeah, I mean, my comment would be, if it's important to try to recognize hereditary syndromes. Not always easy. So with neuroendocrine tumors, we often think of MEN1 with pancreatic nets, which are associated, of course, with pituitary and parathyroid tumors. And von Hippel-Lindau syndrome is less common in the neuroendocrine tumor space, but if they have a family history, if they have other tumors or lesions that are suggestive of that, then it's important to think about it because we now have a drug that targets this disease.
Well, also to the audience, belzutifan is being studied in a sporadic RCC, so who knows? Maybe it will end up being utilized commonly. Let's see if we can do maybe another case here. You were talking earlier about the misperception that chemo doesn't work in NETs. This case sort of gets into that. A 60-year-old man with symptomatic metastatic hypervascular pancreatic neck with bulky liver mets. Here's Dr. Kunz.
This is a 60-year-old, otherwise healthy man with a 2-month history of left lower quadrant cramping, GI upset, low appetite, and a 5-pound weight loss. A CT scan showed a hypervascular pancreatic mass and I would say pretty bulky liver lesions. The liver biopsy showed a well-differentiated WHO grade 2, Ki-67 3% net. So you can see I put in 2 pictures here that show both the pancreatic lesion that's kind of near the spleen with hypervascular liver lesions and both of the cross sections. I'll mention a pretty key takeaway, though this is an MRI. The mainstay of monitoring patients on NETs is with either an MRI or a CT scan with contrast. We gave him capecitabine temozolomide, and I'll tell you why. So I was worried he was symptomatic. He had bulky disease. I felt that a primary goal of treatment for him was objective response. Like I needed his lesions to shrink in order for him to feel better. Starting off with bulky disease in the liver, I knew that the liver and liver failure would be a real potential future problem for him. So if I can get tumor shrinkage early, that's going to make me feel better, and then I consider some of these other therapies. So if you have a patient with a pancreatic NET for whom you're worried about like bulky tumors that are causing symptoms, capecitabine temozolomide is really the way to go.
So agree, disagree, or in between? Any thoughts about the case? Any alternative strategies you might have thought about?
No, I agree 100%. As far as efficacy, achieving tumor shrinkage, chemotherapy is probably the way to go, and capecitabine temozolomide is a regimen that's well tolerated. It's oral, and the response rates are roughly 50%, and the median time to progression is quite long. It's almost 2 years. So I think that's a good option. If the tumors are somatostatin receptor positive, I would say that PRRT with lutetium dotatate would be a reasonable option as well. So those are probably the 2 options that are associated with the highest response rates. One thing I want to mention, when oncologists prescribe capecitabine temozolomide, we often see issues that could be done better. So for example, any time a patient gets temozolomide, it's extremely important that they get ondansetron, prophylaxis 30 to 60 minutes before. Otherwise, they get quite nauseous. So So we give it, we prescribe it along with an instruction sheet because it's a little bit of a complicated regimen, and it's very important that the patients know how to take these drugs properly. Another thing is it's important to check labs right before starting each cycle. It's 2 weeks on, 2 weeks off. The time to check is right before each cycle. If they start developing thrombocytopenia, platelet count under 100 at the week 4 mark, hold the treatment, keep an eye because it can nadir, and then you can get delayed nadirs with temozolomide. So, it's important that patients know how to take it and that it's prescribed properly and monitored properly.
So you were mentioning when we started about the heterogeneity of NET. What about chemotherapy in the various pockets of NET? Does it work in general across the NET tumors or more in specific ones?
Right. So pancreatic NETs seem to be the most chemosensitive. Small bowel, midgut NETs seem to be the least chemosensitive. Response rates are almost never seen to cytotoxic chemotherapy. Lung NETs are probably intermediate, less than pancreatic, but more than small bowel. And you can use capecitabine temozolomide in lung NETs. The data is relatively limited, but if they're typical, atypical, in other words, well differentiated, it might work better than platinum etoposide. And then there are rare subtypes where there's very little data, like rectal, gastroduodenal. It's very hard to know what the efficacy is because they're so rare.
Nabin in the chat room wants to know about bladder neuroendocrine tumors and prostate neuroendocrine tumors.
Those are almost always poorly differentiated neuroendocrine carcinomas. They're almost never well differentiated. Prostate can start as adenocarcinoma and dedifferentiate into neuroendocrine. With respect to neuroendocrine carcinomas outside the lung, we have very little data. We're still using platinum etoposide with very little knowledge about what works beyond that. There's some data to support dual immunotherapy with ipi-nivo based on small trials. I personally don't treat a lot of prostate neuroendocrine carcinomas, but there's really no reason to think that they behave differently from the rest.
So, Jonathan, thank you so much for joining us, and thanks to Laurie for joining us for this sort of experimental webinar. I didn't embarrass myself, which I'm surprised at because I feel like I hardly know anything about these two topics. Audience, thank you for attending. Come on back tomorrow night. We'll see if Dr. Rajay can enlighten us a little bit about bispecifics in myeloma. We now have teclistamab approved, and of course, CAR-T, where this all comes together. So many questions in myeloma. But we appreciate your coming here tonight. Be safe, stay well, and have a great evening. Thanks so much, Jonathan.
Thank you. Appreciate it.